So I want to welcome everybody to the May chapter meeting. I have a couple of announcements to make, some of which will not be news to you because there are things that I covered in the meeting notice, but I wanted to just reiterate them. Number one, importantly for our group, Governor Inslee did sign the legislation regarding captions on TVs in public spaces.
Yep.
So when we're out and there are TVs on, they should have the captions on. That is now the law of the land. And I know it will help a lot of us as we try to navigate out in the world. So that's really good. And thank you to people that I know that put comments in and egged on both the state legislature and Governor Inslee's office to get that done. Dean Olson from WashCap was especially active, and I also know that the folks from HLAA Washington were active in that effort. So that's really good news. The second thing I mentioned in the update was about this, the two people from Western Washington University who are doing a project on trying to make theaters more accommodating for those of us with hearing loss. And I had a one-on-one interview with Hannah Bodley, who's kind of been my contact person on that. She reached out to me, and I had a conversation with her on Thursday, learned a little bit more about what's going on there. It's actually an engineering class where they're trying to work on accessibility issues and coming up with design ideas for to make better tools for accessibility, I guess is the best way to put it.
Hey,
So
I'm just in a Zoom lecture about vertigo and dizziness.
Hey,
Yeah, thanks, Walter.
Walter, could you mute? Actually, everybody, when you're not talking, if you would mute your microphones. So at any rate, that was a very interesting conversation that I had with Hannah. In the update, the meeting notice email, I gave you a link to a survey that they have on Google. If you would be so kind as to complete that survey, and if you would like to contact Hannah directly, I also gave you her email in that, and you could talk with her one-on-one. I think, you know, those of you who are perhaps a little bit more technically proficient could give them some more insight than I could. But Hannah is a kind of a self-described nerd, and she's really passionate about trying to make this a meaningful project. It's not just something she's doing because the professor told her she had to. She cares about this. So I encourage us all to support them however we can. So that's all the good news. I have some not so good news for you. And that is that Bill Collison, who's a member and has been active in our group for a while. He was also on the Washington State Board, treasurer of the Washington State organization. I got an email from his wife last night that I knew he was in hospice care, but he was in his final hours last night, according to Andy. So please dedicate some thoughts to Bill's family as that goes on. That's a tough one for me. I had a kind of a really good relationship with Bill and I learned a lot from him in a short period of time. Not about hearing loss, but just about being a human being. So we also have Charlene. I know you've got some information on Wayne Goddard's situation. So, but I'm not seeing Charlene on my little chart now. There she is. Okay. Charlene, you're muted. Charlene, you're on mute. There we go.
I know better than that. Wayne had a pacemaker implanted last Monday in an effort to calm his heart rate down and make it more regular. It's a question whether or not it's working. He's back in the hospital now with a touch of pneumonia in one of his lungs. So we need to keep him in our thoughts and hearts for his recovery. I called on him the week before and spent quite a bit of time with them both. And both he and Darlene were pretty concerned about the situation.
Okay, thanks, Charlene. All right. Does anyone have anything else that they would like to share with the group before we get started with what I know is going to be a very interesting presentation? Seeing no raised hands, I'm going to turn it over to Pam and ask her to introduce Dr. Hume.
Morning, everyone. Good morning, Dr. Hume. It's nice that you've joined us today. We've had Dr. Hume come and speak with us on several occasions over the years, and it's always been very enlightening and very interesting. He is a University of Washington Associate Professor of Head and Neck Surgery and a researcher at the Virginian Merle Blodell Hearing Research Center. He practices at University of Washington Medical Center, Harborview, Eastside Specialty Clinic, and the VA Puget Sound.
Wow.
Yeah, he's very busy. I'm always amazed the capacity of you. And Dr. Hume is passionate about providing comprehensive and compassionate care to all his patients. His goal is to help patients understand treatment options from the perspective of their own values and guide them along their chosen path. He earned his medical MD at Cornell University. He runs the research program at University of Washington and is affiliate of the University of Washington Center on Human Development and Disability, as well as the Institute for Stem Cell and Regenerative Medicine. He specializes in medical and surgical management of diseases of the ear, and he has expertise in middle ear surgery, hearing aids. So thank you, Dr. Hume, for joining us, and we are really looking forward to your presentation.
Well, thanks for inviting me. It looks like a beautiful day outside, so I appreciate your spending your time on a Zoom call when it's so nice. I'm going to try to share my slides here and see how this works. Are you seeing my slides?
Not on the main screen. I see them on the side, but not on the main area.
Let me see if I can. Let me try something else, sorry. So you're still not seeing my slides there?
No, not yet.
No. All right, let's try something else here.
While you're doing that, Dr. Hume, let me just remind people, number one, you can move the captions if they're blocking you by just putting your mouse in the box where the caption is, holding down the mouse and dragging it. Number two, if you go to view options at the top, you can go to side-by-side mode. You will be able to see Dr. Hume on one side of your screen and his slides on the other. We are now seeing your slides, but since I'm talking, we're not seeing you. I want to adjust the ratio between Dr. Hume's slides and his video feed. Over by the picture, you will see a vertical line. Just put your cursor over that vertical line and move it, and you can change the size of those two boxes. So that's how you can maximize the value of this screen sharing. So now I will shut up and we'll turn it over to Dr. Hume.
So you are seeing my slide there successfully then?
Yeah.
Yes.
Okay. Sorry about that. Now let's just see if I can get it to advance now. I did the slide advance. Did you see the slide advance to the second slide?
Yes. Now we have key points up.
Yes.
Okay, perfect. All right. So it looks like it's working now. Sorry about that. So I want to go a little bit over some different issues related to dizziness and vertigo and imbalance, and kind of relate some of that actually to the process of aging and sort of how aging affects the balance system. And really just to remind you that dizziness, even though it's common, is not really an unavoidable consequence of normal aging. And when we have those symptoms, they can either indicate a loss of peripheral function, by that I mean inner ear function, or a central nervous system dysfunction. And again, by that I typically mean how the brain or other sensory systems work with the inner ear. Or it can be related to muscle weakness, arthritis, anxiety, or sometimes even cognitive changes that are associated with aging. And in terms of understanding how dizziness can affect people during the aging process, the key is to find, a diagnosis and then to figure out what the risks are that might entail to the patient, but also what options there are for treatment. And something which becomes more relevant in the work that we do is we do have some very specialized testing that sometimes can be very helpful in kind of assessing the degree of damage to the inner ear with the aging process or from other conditions, and help direct treatment. So I'm going to talk a little bit about the impact of dizziness and really how we define different kind of ways we describe dizziness, how the inner ear works and how the vestibular system works, and then describe how we use a fairly standardized approach to try to find a diagnosis for each individual, and then review some of the ways that we treat some of these different kinds of more common dizziness, and then how we might, in some cases, encourage, for example, primary care providers or other medical providers, how the testing that we can perform in our testing laboratory can be helpful in designing new treatments. So dizziness and vertigo are incredibly common and account for about 15% of all primary care visits. And those can be either related to, again, vestibular, what we call peripheral problems with the inner ear, which is at least half, probably overall. And the most common of those is benign paroxysmal positional vertigo. And that's followed by vestibular neuritis, which is an inflammatory disorder of the balanced nerve, and then Meniere's disease. But other conditions are also common in primary care visits that can cause these types of symptoms, and they can be cardiovascular disease from low blood pressure, or atherosclerotic disease, neurologic problems, psychogenic problems. In some cases, there really isn't a clear diagnosis, or maybe it's multiple diagnoses. So even though we think of these things as not being life-threatening, and the majority of the causes for these types of dizziness are benign, it doesn't mean they don't have a severe and potentially fatal impact on patients. It also doesn't affect people the same across the span of aging. So if we look at a 1-year prevalence of dizziness in the population, about 20% of the people over the age of 60 have dizziness, but that increases up to about 50% of individuals over the age of 85. And many of these individuals never access the medical system. So many people with dizziness and balance problems are never actually evaluated for those conditions. And they, again, may assume that that's sort of a natural part of aging. And the impacts can be multiple medical visits. They can be lost work. Because of the dizziness symptoms, they may not participate in social activities or change the way they participate. These types of symptoms can also lead to problems with their gait, which can then lead to falls, and then subsequently to wrist fractures, hip fractures. All these things have been shown to be more frequent in problems with dizziness. That then starts a vicious cycle where, because of the fear of falling, that actually increases the risk of falling. And so it's sort of a vicious cycle that worsens how people are able to participate in the things that they want to do. What's been very intriguing in the last probably decade or so is there's also an increasing appreciation that people with vestibular problems or inner ear problems affecting dizziness may actually also have problems with cognition. And the link between vestibular loss or balance changes, just like the effects of the role of hearing loss with cognitive changes, are becoming more and more appreciated, even though we don't understand really that association very well yet. So we end up in this sort of mess of problems with how patients are affected by dizziness, the kind of effects it has on their life through many different ways. And also it's very difficult for people to describe. So it's hard for an individual to really kind of communicate what it is they're experiencing in a way that a medical provider can try to arrive at a diagnosis and treatment. So what do we mean by dizziness? You know, people might say they're dizzy, they're faint, they're lightheaded, they feel a spinning sensation, they're spacey or drunk, swaying, spinning, just off balance. All these different types of things may describe different conditions affecting the inner ear or causing dizziness symptoms. So one thing that's very helpful is to use a sort of standardized terminology. And this is an outline that was developed by a large interdisciplinary group on people with, on individuals studying vestibular disorders. So by dizziness, we mean a sense of spatial disorientation, but without motion. Whereas vertigo means a sense of self-motion or environmental motion when there actually isn't any motion. And so sometimes it's really more of a distorted sense of self-motion with normal movement. And those are contrasted by unsteadiness, which is sort of an instability, which can even happen when seated or when standing or walking. And that's probably synonymous to disequilibrium or imbalance. Now, those are slightly different from some of the other symptoms that might sometimes be described as dizziness. So pre-syncope is the sense that you might faint, so an impending loss of consciousness. And syncope is when somebody actually does faint and there's a transient loss of consciousness, but a full recovery. Generally, that's fairly short duration, but it's associated with a loss of postural control and falling. So those are sort of distinct types of dizziness that people might describe. And we're really going to focus on the ones on the left-hand side that in general are more likely related to inner ear problems or to how those that type of sensory information is processed by the central nervous system. And so we're going to focus on how do we diagnose some of these disorders and how do we define a treatment plan, and then how can we help patients understand what that means in the long term for their possibility of recovery. So if we look at a specialized dizziness clinic, and this is one in Germany, so this is not the general population, but a dizziness clinic, you can see that, let's see if my pointer is working here. The ones in red here are different types of dizziness that are caused by a central nervous system disorder. And overall, that's about 25%. But you can see the ones in yellow and blue and green. These are a whole assortment of different things that can cause dizziness. There's not really one overwhelming diagnosis for these kind of conditions. And that's important to remember. And that's what makes it challenging sometimes to diagnose somebody, is there many possible things that can cause dizziness. If we look at the diagnosis of dizziness across aging, so in this graph, it's showing in the lighter bar, individuals less than 40, and in the darker bar, individuals greater than 80. These are some of the common diagnoses that were found, and again, in a specialized clinic. So BVH is bilateral vestibular hypofunction. So that's when essentially the balance function in the inner ear has gradually been lost, either due to the aging process or some other event. CV is central vertigo. So again, this would be sort of a central nervous system cause of dizziness. BPPV, which we've mentioned briefly, and I'll come back to in more detail, is benign paroxysmal positional vertigo. That's the positionally triggered vertigo. It's fairly common in both groups of ages. The other one I'm going to focus on here, this is unilateral vestibular dysfunction, so loss of balance function in one ear. 3PD is persistent postural perceptual dizziness. It's also called chronic subjective dizziness. Very common in the younger population, but not so common in those over 80. Meniere's disease, vestibular migraine, again, is another one very common in the younger population, but not very common in those over 80. Vestibular paroxysmia, not very common really in either population. And OC is other causes where there may be multiple different things contributing to the symptoms. So again, it's critical to understand in specific individuals that the types of things that may cause dizziness can be quite different according to the age. If we think about how the balance system works, it's really a coordinated set of reflex pathways that primarily stabilize vision, but they also stabilize posture and control movement and balance. And really, it's a coordinated integration by the brain of visual sensory information, proprioception from your feet, your ankles, your knees, your hips, and then an integration by the central nervous system. So all those different things have to work together. So one way I think it's helpful to think about how the vestibular system works is as a three-legged stool. So the primary sensory systems that we utilize are vestibular information or inner ear balance information, vision, and then proprioception. Each one of those legs of the stool is connected to the brain, which is the central coordinating center. So if somebody has problems with dizziness or with their balance, it could be a problem with multiple legs of the stool, but also with how the brain is working. And it can be any combination of all those. What's helpful, I think, to understand primarily the vestibular part of this equation here is to think about the anatomy of the inner ear. And this shows a diagram of both the hearing part of the ear, so the cochlea, as well as the vestibular part of the inner ear. And altogether, this is called the labyrinth, sort of the channels within the bone of the inner ear. And if we focus on the balance part of the inner ear, there are the three semicircular canals, and they're oriented sort of at 90 degrees to each other. We're going to come back to the specifics of how they're oriented in a second, but it's shadowed in with this head back here. And you can see that they're not oriented in the same planes that we think of as anterior, posterior, and lateral. So we have the three balance canals. Then we have the utricle and the saccule that are called the otolithic organs, and they're the ones that have small grains of calcium carbonate crystals. and those respond to acceleration, either related to gravity or to movement, whereas the semicircular canals respond to rotational velocity changes. If we look inside those balance organs, this is an example of the crista ampullaris, which is within one of those semicircular canals. There are the sensory hair cells that are in blue here and the nerve fibers coming in. These are very similar to the hair cells that are found in the hearing part of the ear in the cochlea. But in this case, in this whole fluid space here is filled with fluid, there's a gelatinous matrix sitting on top of these hair cells. So when fluid moves inside these balance canals, when you turn your head, the fluid causes this cupula to deflect, and it bends the tops of these hair cells, which then stimulates that component of the balance nerve. Now, within the otolithic organs, like the utricle and the saccule, there's also this gelatinous matrix over the top, but on top of that, there are these small calcium carbonate crystal called otoliths. And then what happens when somebody moves is there's an acceleration where the mass of this debris on the top of the hair cells lags behind, and again causes a moving and a shearing force on the tops of the hair cells, and again stimulates that component of the vestibular nerve. I'm going to come back to the orientation because, again, this is helpful in understanding how the balance system works, but also how these components can sometimes be analyzed in our laboratory. So if we look at the horizontal semicircular canal, even though we call it the horizontal canal, it's actually not oriented in a horizontal plane. It's actually oriented about 30 degrees up. And that's the same plane as the utricle. The anterior semicircular canal and posterior canal are oriented vertically, but they're actually not oriented strictly front to back. If you look on the bottom plane here, you can see that the anterior canal is actually oriented at 45 degrees to the front, and the posterior canal is 45 degrees to the back. And the reason this is important is if we tilt our head as an example, you're not just stimulating one balance canal, but in fact, 4 different balance canals. So both anterior and posterior canals on each side. Or if you turn your head, you're going to stimulate these horizontal canals, but they're actually not in the same plane that you're moving your head. Now, the way these work in terms of controlling the stimulation of the vestibular nerve, the balance nerve, is there's a sort of an ongoing signal that's coming from that nerve, which is represented by this tracing here. And any kind of a movement will modulate this tracing, modulate the discharge from that nerve that sends a signal to the upper centers in the vestibular system in the brainstem. And this is a diagram showing that pathway. So if we look at where the inner ear is, this is the vestibular ganglion where the neurons are for the vestibular system. They're out in the inner ear. They send a process into the brainstem, into what's called the vestibular nucleus. So it's a collection of the neurons in the brainstem that respond to balance signals from the inner ear. But they also send a process to the cerebellum. And that's very important because that's what actually allows us to compensate for changes in how our vestibular system works. From this vestibular nucleus, there are also connections to these other nuclei, again, collections of neurons that control eye movements. So these 3 groups here are all different collections of neurons that control the eye movements. And that's critical because one of the major reasons that we have the vestibular system, as I mentioned, is to control eye movements. If we look on this diagram, this shows the 3 main reflexes that are controlled by the inner ear that help us maintain those things we talked about. So a stable visual image, our head posture on our head position on our neck, and our posture in general. So the vestibulo-ocular reflex, vestibular system with the inner ear, ocular with vision, and the reflex is what we use to control eye movements with head changes in the horizontal plane. The vestibulo-colic reflex controls our head on our shoulders, and vestibulospinal controls our body position and posture. If we focus on the vestibular ocular reflex, this is what allows us to see when we move. So if we turn these big arrows here are reflecting that the head is turning towards the left-hand side. So in order for us to keep an image focused on our eye, focused on our retina, our eyes have to move exactly in the opposite direction by the same amount and the same velocity. If that doesn't happen, then we end up with a blurred image on our retina. And this shows what's happening in the inner ear. So if we move our head to the left, the fluid inside that horizontal canal moves in the opposite direction in both ears, and it stimulates the inner ear to control those neurons that control eye movements that I showed you in the last slide. And those control the muscles that actually regulate the position of the eyes. This happens incredibly fast. So within 15 milliseconds, the inner ear can detect movements of your head and correct the position of the eye. So even for movements as small as the beating of your heartbeat, your vestibular system is able to correct the position of your eye so things aren't blurry. If this doesn't work, this is what happens. So in a normal eye chart, the Snellen eye chart, the letters should be very clear and sharp. But if your inner ear is not able to stabilize how your eyes are positioned, this is what happens. There's a blurring of vision. And sometimes when people are walking, they describe it as their eyes are bouncing in their head and they just can't focus. So in order to see, they have to very slowly move their head. Very, very challenging and disabling. And this is what we would see in somebody who's lost all balance function. So how does aging affect the balance system? So it affects it at multiple levels. So in the inner ear, there's a loss of those hair cells that I showed you, but that's relatively slow. So maybe at about 6% a year, but over the lifespan. There's also a change in the neurons that innervate those hair cells, and that begins at a somewhat later age, but is more rapid in the elderly. So again, maybe a more predominant thing with aging. And there are also changes in notoconia. So again, those little calcium carbonate crystals, over time, they actually become less stable and more turnover. And that's why we find that conditions such as benign paroxysmal positional vertigo are more common in the elderly. There are also changes in the brain. So in those collections of the neurons in the brainstem, the vestibular nuclei, those also decline with aging. It turns out that may be less dramatic in terms of the symptoms because, again, of our ability to compensate with our brain. So despite these changes, it turns out that overall, again, because of our ability of the brain and the cerebellum in particular to compensate for loss of these peripheral changes, many people don't experience a decline in balance function with aging. In conditions that are associated with aging, one is called presby, which means aging, vestibulopathy, or loss of balance function. That can be associated with changes in balance, gait, just dizziness and falls. And this is really a mild version of loss of balance function in both ears. There's also another condition called multisensory dizziness, which not only includes the loss of balance function in the inner ear, excuse me, but also the impacts of visual loss with aging, peripheral neuropathy, potentially cardiac and cardiovascular, cerebrovascular perfusion, so brain perfusion. Those are all things that may contribute to that type of a syndrome. So the key to diagnosis of these different types of conditions really is the timing. So when do the dizziness symptoms occur and how long they last? And what are the triggers? Are there specific types of triggers that are causing an individual to be symptomatic? So for very short-lasting symptoms of dizziness, lasting seconds to minutes, there are really only a couple things that can cause that. And as I mentioned before, by far the most common one is benign paroxysmal positional vertigo that we're going to talk about in more detail. But that's triggered by very specific position changes. There can also be dizziness that's very brief, triggered by sound, very intense sound or pressure changes, such as lifting something heavy. The most common but fairly unusual diagnosis for that is called superior canal dehiscence syndrome. There are also other conditions that we call fistulas, where there's actually a leakage of fluid from the inner ear, but that's actually relatively uncommon as well. For dizziness symptoms lasting minutes to hours, the most common causes, as I showed earlier, in the majority of the population is vestibular migraine, and we'll talk about that. Less commonly, but frequently seen by me in a subspecialty ear clinic is Meniere's disease. For dizziness that's lasting days to weeks, that can sometimes relate to somebody who's had vestibular neuritis or inflammation of the balanced nerve. Labyrinthitis, when that same inflammatory process affects hearing as well. Migraine, again, and then some other conditions which may be related to other health disorders. For dizziness that's lasting more than 3 months, often with sort of a vague sense of imbalance or dizziness, the most common diagnosis is what's called chronic subjective dizziness, which we'll also talk about briefly, and less frequently, mal de débarquement, which is a specific type of dizziness that's chronic in nature, but is triggered by something as, for example, being on a cruise or sometimes being on a train or something like that, that we'll talk about briefly. So how do we arrive at the diagnosis? As I mentioned, it has to do with timing and triggers. So for dizziness that's triggered episodically in short events, for triggered types, we use a specific type of a maneuver called the Dix-Hallpike maneuver that I'm going to show you what we do for that. If that test is positive, that's really a definitive diagnosis of this condition. It's benign because it really, at least in most people, doesn't have any severe consequences. It's also very treatable. If that test is negative, the most common thing that's triggered by body position changes that causes dizziness is really related to orthostatic hypotension, which means that your blood pressure going to the brain is affected by body position. Now, this doesn't always mean that you have low blood pressure when we measure it on your arm. It means that the perfusion or the blood supply to your brain changes with body position. And sometimes that can be affected by narrowing of the arteries in your neck, for example, or irregular heart rate. So even if you have normal blood pressure, you can still have changes in blood pressure affecting the balance centers in the brain, causing positionally triggered dizziness. For spontaneous dizziness that's short in duration, if it's associated with hearing loss, the most common diagnosis is Meniere's disease. In somebody who's had a history of migraine headaches, we'll come back to, the most common diagnosis is vestibular migraine. And even though we're saying it's spontaneous, we can often identify triggers that may be responsible for leading to vestibular migraine attacks. There also can be dizziness triggered by panic disorders, anxiety. And again, those are very treatable in many situations. For continuous dizziness, sometimes that can be related to treatment with different kinds of medications. So a common one, especially when people are taking multiple kinds of medications that may interact both with the inner ear, but also with how the brain compensates for damage to the inner ear and with blood pressure regulation. That can also be caused by barotrauma, which, for example, can be rapid descent in an airplane or with scuba diving or something like that, can cause some leakage of fluid from the inner ear, as I mentioned with a fistula earlier. With continuous dizziness that comes on spontaneously with no obvious trigger, there's a specific type of examination that is abbreviated as HINTS that I'll briefly refer to. And really the key there is that for spontaneous severe vertigo that comes on without a trigger, our biggest concern is this a stroke? Is this something that's concerning in terms of your health, which needs to be treated acutely? Or is this vestibular neuritis, which is limited to the balanced nerve and generally is very treatable and recoverable? So that's kind of the critical thing, is to distinguish between having a stroke or having vestibular neuritis, or this inflammatory condition of the inner ear. Trying to find my pointer again. Let's see if that works. Here. So those are the two physical exam findings that we use to distinguish the concerning conditions. So the Dix-Hallpike is the technique that we use to diagnose benign paroxysmal positional vertigo. And this shows the position of the head, obviously. And this shows what's happening in inner ear as we put it through just some different positions. And this little black spots here are representing those otolith crystals that have been dislodged from the utricle, which is sitting over here. So the crystals have gotten into this posterior semicircular canal, and they're sitting in this fluid in the canal. So what happens when you move? So those little crystals are going to actually slide around. And so the positions here reference to the numbers up here. So when you tilt your head back, you can see those crystals have actually slid through this canal And as they do that, they drag the fluid inside the canal and stimulate a very typical movement of the eyes, which is shown down below. So if the individual is looking straight ahead, the eyes are going to rotate with sort of a torsional twisting motion, and they're also going to be up. And this is very easily observed if somebody has this. You can, just looking at their eyes, you can see the eyes kind of jumping in their head with a very quick jump and then a slow return. So a quick jump and a slow return. And the pattern of the eye movements that occurs is specifically triggered by these balanced canals. And that's important because that allows us, with observing the types of eye movements, to actually diagnose specifically which one of these 6 balanced canals is involved. So the diagnosis for benign paroxysmal positional vertigo is really based completely on this physical exam finding. And that's actually quite helpful because it allows us to know that this is not something like a stroke, that we can reassure the patient, and in fact, it's very treatable with physical therapy. The other test which I mentioned is the HINTS test, which stands for Head Impulsed Negative Test of Skew. I won't go through the details of this, but again, it's something that can be done very easily by a primary care provider or an emergency room. And really, it's most useful in patients that really have severe vertigo that comes on suddenly. The head impulse test is a test where the individual looks to the side and they focus on your nose and quickly return the head to the middle. And what that allows, in a normal situation, the eyes will remain focused on a target. If they do this maneuver and their eyes lag behind, so I'm not sure if you can see my head or not, but if I look my head to the side, I'm looking at your nose and I pop it back, the normal situation, the eyes don't move. In an abnormal test, when I move, my eyes actually take a bit of a delay. So they delay until they catch up and look back at my nose. So that's what we would expect to see if there was an inner ear injury with a loss of function in the inner ear, because it can no longer provide that response that corrects our eye position. On the other hand, if somebody is having a stroke, that reflex is intact and the eyes remain fixed on the nose. Nystagmus is describing that type of eye movement that I was showing you with the Dix-Hallpike diagram. And then test of skew is really a test where if somebody's looking ahead, both eyes should be arranged in the same plane. If we cover one eye and we uncover it, the eye should still be in the same plane. In an abnormal test, when we uncover the eye, we see the eyes are no longer aligned properly. When we remove the block of the other eye, it will recorrect. So that tells us that something in the brainstem is actually not correctly coordinating eye movements. And that's, again, something that's concerning for having had a stroke. So for any type of dizziness, whether it's acute or chronic, the first goal is to try to treat the symptoms so that the individual is more comfortable and able to perform the things that they need to do. On a more long-term, of course, the goal is to try to return to a steady state so that people can prevent recurrence, but also, again, prevent potentially long-term problems associated with this condition. So there are different ways that can be done. In some settings, there can be medications that can help with that, physical therapy, and in a small percentage of people, there may be surgical options that we use to treat dizziness. So in terms of medications, there are many medications that are used, many different types and mechanisms that they work. Most of these are fairly blunt. So I think of them sort of as a sledgehammer approach to treating dizziness, but in the short term, they can be very effective. So some of these suppress the balance system. So we call these vestibular suppressants. They can be helpful for some of the vertigo and nausea symptoms. And they may also work on some of the things, some of the autonomic centers, which control, again, our sense of nausea. There are other medications that can control the nausea without affecting the vertigo itself. Common one that might be used for this would be ondansetron or Zofran that some people might be familiar with. And then individuals that have migraines, there are whole classes of medications that can be used to prevent migraines or to treat migraines acutely. So the choice of the drug is really dependent on how severe the symptoms are and whether or not they're recurrent or chronic mild symptoms. So with somebody with severe symptoms, we obviously want something that's fairly sedating so that they can recover. And typical medications might be promethazine or lorazepam. And that will allow them to basically recover and then get back to normal activity. Whereas somebody who's having chronic symptoms or recurrent chronic symptoms, who might want something that's less sedating so they're not sleepy and groggy, so they can actually continue to work and so forth. What I want to really emphasize is that medications are not used for treatment of benign paroxysmal positional vertigo, and they're not used for people with bilateral vestibular hypofunction. And again, that's critical because these are both conditions that are more common in the aging population, and unfortunately, many times are treated with medications, which is inappropriate. So we want any medications, we want to minimize in the long term the amount that they actually suppress the balance system and suppress this and not cause sedation, because those are the things exactly that we need to try to recover. So coming back to benign paroxysmal positional vertigo, in this case, the Dix-Hall-Pike maneuver shows what's happening in the left ear where these little crystals move and trigger these eye movements that I showed you. The treatment for that is what's called an Epley maneuver, and I'll show you that in just a second here. So benign paroxysmal positional vertigo usually affects that posterior semicircular canal. It can also affect the horizontal canal or the anterior canal. And there are different types of eye movements that I've kind of listed out here, not that important for you to pay attention to today, but only to tell you that we can distinguish all 6 canals based on that maneuver that I showed you. This is what the Epley maneuver looks like. So starting at the top here, the head's turned at about 45 degrees. And in this case, we're talking about an individual with an involvement of the right posterior semicircular canal. They then lay back and their head is tilted back at least 20 degrees. And inside the inner ear, you can see what's happening to the debris. Again, it kind of gradually shifts as you go through this sequence of maneuvers. The debris moves through the canal and drops back into the utricle where it's not going to irritate the ampulla again. And this treatment's very effective, probably 85–90% effective in treating BPPV. And it's more effective, even more effective, it's repeated multiple times. And so this is something that can often be done without even, basically straight from having symptoms to going to a physical therapist can be successful in resolving this problem. For the other types of BPPV, so this is the horizontal semicircular canal, there are other maneuvers. They're slightly different in order to get the debris out of the horizontal canal. They're also effective. And in fact, for the horizontal canal, it often resolves spontaneously. There is an increased recurrence of BPPV in the elderly. And again, we think, as I mentioned earlier, that's probably because these otoconal debris is less firmly attached with aging. It's also more likely that there's a gradual loss of these hair cells, as I mentioned before, that stabilizes this debris, the otoconia. So with aging, more likely that BPPV can be happening. There is some evidence that in individuals who have recurrent BPPV, this may be related to deficiency of vitamin D. And this is a fairly recent finding. And so in this situation, this was a study done actually in Korea. And what they found was in individuals, if you look at in time with a number of recurrences of BPPV, in individuals that had supplementation with vitamin D and calcium, they had a lower rate of recurrence of BPPV compared to those that did not have supplementation. And there are a number of other studies that have shown the same thing. And so there's a little bit of evidence that vitamin D supplementation with calcium might be helpful in preventing recurrence. So that's something I generally recommend to my patients if they've had multiple episodes. Now, is BPPV really benign? So that's the other question. Even though we call it benign paroxysmal positional vertigo, there's some evidence that individuals who've been seen in an emergency room, clearly diagnosed with BPPV, may actually be at a higher rate of risk for strokes. Now, why does that happen? We don't really know, but it suggests that maybe there's a gradual degeneration of the inner ear that's related to, for example, cerebrovascular disease, and that the reason BPPV happens more frequently is because of that gradual degeneration. And that might be another sort of hallmark of loss of function in the vascular system that may also potentially lead to a stroke. Meniere's disease, one of the other conditions that's relatively frequently seen, again, the clear defining part of this is vertigo symptoms that last from 20 minutes to 12 hours. There's a fluctuating hearing loss that typically is in the lower tones. And it's also associated with tinnitus or ringing in the ears or oral fullness that usually happens with the attack, but often becomes more persistent in the affected ear with time. And in some cases, the hearing loss actually precedes the vertigo. The onset of Meniere's disease is typically in the range of 20 to 50 years old, but it's actually very rare. So about 0.2% of the population has Meniere's disease. We think what causes this is actually a dilation or kind of increase in the size of some of the fluid spaces in the inner ear. That's shown in this diagram here. So the blue shows what's called the endolymphatic fluid space in the inner ear. And in a normal ear, you can see that this fluid space is within the cochlea as well as within the labyrinth. What happens in Meniere's disease is this fluid space that's in blue basically expands to fill almost the entire vestibular labyrinth. It also expands in the cochlea, the inner ear, for the hearing part of the inner ear, and leads to this gradual changes with loss of hearing and the episodes of dizziness. We still don't really know, even though we have a better understanding of what happens with Meniere's disease, we still don't really know why people get it. And there's a number of different etiologies that have been proposed, whether it's related to a viral inflammatory disorder, autoimmune disorder, or maybe in some cases, potentially even some involvement of genetics, but we really still don't understand. The therapy usually is to follow a low salt diet, which is a pretty low salt diet. And again, the thought is that the fluid spaces in the inner ear are regulated in a similar way to what we might think of what the kidney does for regulating fluid balance in your body. And by decreasing the salt intake, we can change the fluid balance in the inner ear. Stress reduction seems to be helpful. And then some dietary triggers such as caffeine and nicotine cessation can also be things that will be helpful. In some individuals, there seems to be an allergic component. So doing allergy testing or treating allergies may be helpful. And then if these things are not successful, we often will put individuals on a diuretic, which again affects fluid balance with the kidneys if people have high blood pressure, but also affects fluid balance in the inner ear. And about 80% of people with Meniere's disease can be managed with medications and no further intervention. Now, there's a lot of overlap between the symptoms of Meniere's disease and what we call vestibular migraine. So some of the common symptoms are the vertigo attacks, the ringing in the ears, some degree of hearing loss, and a sense of pressure or fullness in the ears. What may be exclusive to vestibular migraine is sensitivity to lights, sensitivity to sounds, and a history of headache or concurrent headaches that we see in individuals who suffer from migraine. But what's important to realize is that the migraine headaches do not have to be at the same time when people are having the dizzy attacks. So we frequently see individuals that may have had migraines many years ago, even only as a child, and now have vestibular migraine with no headaches, but only dizzy attacks. So almost a complete overlap of the symptoms. Really, the only thing which is exclusive to Meniere's disease is that progressive hearing loss, typically in 1 year. And one way I like to think of migraine is really a syndrome of sensitivity to multiple sensory stimuli, whether it's light, whether it's sound, whether it's smells, visual, all kinds of visual stimulation, sensitivity to movement with motion sickness. So the strict diagnosis of vestibular migraine, according to the International Headache Society, is listed out here. And that's really 5 episodes of these types of vestibular symptoms that can last anywhere from a couple minutes up to 3 days. They have to have had a history of migraine or potentially previous migraine. And in some cases, this may only be a strong family history of migraine. And one or more of these episodes have to have some of these symptoms that I mentioned in the last slide. So the vestibular symptoms can be spontaneous vertigo, it can be positionally triggered, it can be visually triggered, it can be caused by motion. So a wide variation of the types of dizziness symptoms that can be experienced. And again, the headache and the vertigo do not have to occur at the same time, and many individuals no longer have headaches, they only have the dizziness symptoms. Migraine is much, much more common than Meniere's disease. So about 18% of women have experienced migraines, 6% of men. And many of these people even with the diagnosis just of migraine have episodic vertigo. So that accounts for about 3 to 4% of the population. Whereas Meniere's disease, about 0.2%, So migraine is at least 20% as common as Meniere's disease. So what's the mechanism that migraine causes these symptoms? So this has to do with the blood vessels that innervate the inner ear and the nerves that are associated with not only the inner ear, but also the lining around the brain. And this is called the trigeminal vascular system. So the trigeminal is the trigeminal nerve, the cranial nerve that innervates those structures. And then the blood vessels or vascular system that also goes to those areas. And there's a reflex where different neurotransmitters are released that cause a dilation of blood vessels in the inner ear, a change in fluid balance, kind of similar to the ideas we talked about with Meniere's disease. And that leads to the hearing loss, the ringing, and the dizziness. So for vestibular migraine, again, very common disorder, one of the most frequent things I see in my clinic for people with dizziness. It's really important that we explore a history of headaches, the sensitivity to different kinds of environmental stimuli. Sometimes there can be aura or a sense of sinus congestion. Many people with sinus headaches actually have migraine. There may be precipitating factors related to food, sleep, hormonal fluctuations, again, common related to menstrual cycle, and later around the time of menopause. One of the clear things that separates this from Meniere's disease is the duration of vertigo. So lasting up to more than a day, even up to several days, often a family history. And individuals with vestibular migraine often have a history of what's called a benign paroxysmal vertigo of childhood, which is also motion sickness in childhood is commonly associated with people with migraine. The treatment, I mentioned briefly already, but it's kind of related to stress, trigger management. So keeping a diary can be very helpful, related to sleep, stressors, diet, menses, allergy, environmental exposures. There are a number of supplements that are very well tolerated that have been shown in multiple controlled studies to be effective in prevention. So I always recommend magnesium supplementation, vitamin B2 supplementation. There are also a number of medications for treating vestibular migraine, a number of different types. I won't go through the details here, but can be very effective. And because there are multiple classes of preventive medications, sometimes it takes a little bit of time to figure out which medication might be effective for a specific individual. In terms of surgical management of vertigo, it's actually very rare. There are a few situations where surgery can be helpful. And primarily that's in the situation where we have fluctuating function of one inner ear. And this is probably less than 10% of patients who have episodic vertigo. So if we think about these conditions, really the only ones that are, BPPV is extremely rarely needed to be treated by surgery, almost always by physical therapy. There's a condition called superior canal Dizziness syndrome that I'll show you a little bit about in a second. Meniere's disease, again, rarely treated by surgery these days. Individuals with post-labyrinthitis, so who had vestibular neuritis and episodic dizziness from that, sometimes are treated with surgery. And the real goal of any surgery is to stabilize that fluctuating function so that our brain can stabilize, so that we can compensate. So superior canal syndrome is not a very common disorder, but it's very it's interesting from sort of a physiologic point of view. These are individuals who have vertigo with loud noises, sometimes sneezing or coughing, lifting something heavy, or for example, blowing their nose will make them dizzy. On top of that, they may have a constant sense of disequilibrium. And they also are very sensitive to sounds through bone conduction, which means that, for example, they might hear their heartbeat, they hear their eyes moving, kind of odd things that people wouldn't normally report unless you ask them. And on hearing tests, they have a very stereotypical hearing loss where they have a conductive hearing loss, which means that the inner ear may work fine. In fact, it may work on testing, may seem to work better than normal, but they have a mild hearing loss. And there's certain tests that can also be used to diagnose this condition. So what happens in the superior canal Dizziness syndrome, this is just a diagram showing the superior semicircular canal and then showing the inner ear, the cochlea is stretched out here. So what happens in the superior canal syndrome is if there's positive pressure inside the brain case, which is sitting up here, this canal is missing bone over the top of it, and pressure by, say, lifting something heavy increases the spinal fluid pressure that pushes in the fluid space inside the inner ear and causes movement of fluid inside the inner ear. And that causes the deflection of the scapula that I showed you happens with movement. Now this is happening with pressure changes. And the treatment for that, if we look at a CT scan, this shows the CT scan looking down from the top, and this shows the superior semicircular canal right here. And normally this should be covered with bone, which in this image is white, whereas gray is fluid or brain tissue. So in this case, we can see there's no bone, there's no white covering the top of this canal. If we look at it along the direction of this arrow, you can see the white here. This is bone on either side, but there's missing bone in this top part of the canal. So when the fluid pressure increases on the outside, again, that pushes in the fluid inside the inner ear, moves that fluid inside the inner ear, and triggers the dizziness that these individuals experience. So the surgical treatment is basically to patch this canal, to put some bone over the top, or to block it off so that the fluid doesn't change with pressure changes. So the rationale for any type of a procedure we're going to remove balance function is because, going the wrong way, is that the central nervous system cannot compensate if the ear is constantly fluctuating. And so if medical therapy doesn't work, the goal of any sort of ablative procedure that removes function is to trade what might be a non-functional ear for one which is fluctuating and not able to be compensated. There's another condition I want to mention briefly because it's quite common. It's called persistent postural perceptual dizziness. There are other names that have been used for this. Chronic subjective dizziness was one of the other names used in the past, or I think psychologic dizziness. This is a condition, and one of the real hallmarks of this condition are people that are feel very dizzy with different kinds of visual stimuli. So this would be chaos for somebody with this disorder. And this is the most common disorder where people have chronic dizziness that lasts for more than 3 months at a time. Now, what's interesting about this disorder is that it's caused by multiple different things. And so if we look on this diagram, kind of typical triggers can be either a vestibular crisis. So for example, that could be Meniere's disease. It could be vestibular neuritis. It could be a panic attack. It could be a pre-syncope or a fainting episode. These things may predispose somebody to have sort of onset of this cycle, which is a maladaptive way that the brain adapts to one of these events. So what happens is that the patient sort of changes the way they actually respond to different environmental stimuli, which may be, for example, changing the way they walk, may cause some anxiety, avoidance behaviors. On top of that, that then triggers other things, which can be stiffness of the neck, fear of falling, fear of going out, constant fatigue. And this is where people usually end up in the situation here, where they're very disabled by this condition and can't seem to escape. So the treatment really is vestibular therapy with physical therapists, and in some cases medications, after we've sort of ruled out the other disorders that we talked about. So it's a very treatable disorder, the most common thing we see where people have dizziness going on for more than 3 months at a time. So physical therapy is a key part of the treatment for almost all dizziness disorders. So it can be used in conditions where there's a stable loss of function in the inner ear. So again, after vestibular neuritis, after somebody may have had some type of surgery for affecting the inner ear, or in individuals with bilateral vestibular hypofunction that I mentioned is very commonly associated with aging process. It can also be useful in what we call unstable peripheral problems with the inner ear, like BPPV. And in that case, the treatment is that repositioning maneuver, the Epley that I showed you. Physical therapy can also be useful in some other disorders, like Meniere's disease, central effects on balance, and migraine, even though the treatment might be more related to education and counseling. So the types of strategies that physical therapists use I've listed here. So those can be retraining the vestibulo-ocular reflex, which can happen if somebody has decompensated, for example, after an illness. Gait training, if necessary, learning how to use assistive devices to maintain safety, education about the prognosis of whatever disorder they have, and then additional things related to posture and neck movement control. And then in some cases, even for somebody who suffers from migraines, there can be migraine triggers related to neck stiffness and muscle tension and so forth. So a good resource, if you're interested in this, is through the Neurologic Physical Therapy site, which has a lot of information for patients on these disorders. In some cases, it can be helpful to do some testing. We have a comprehensive testing facilities at the University of Washington, but also at Seattle Children's Hospital and at the Seattle Veterans Hospital. And the testing really is helpful in some cases if these other things don't work. So this is where people often end up in our clinic, is in a neurotology evaluation. So they have persisting symptoms after having tried doing these Epley repositioning maneuvers, or we can't arrive at a definitive diagnosis from our physical exam. So again, we have a comprehensive balance laboratory. I won't go through in detail all the tests, but we can actually measure a number of different aspects of those reflexes that I mentioned. So this is a diagram of the brainstem here and the cerebellum and the inner ear. So we have tests really to look at how all these components work. So in looking at the inner ear itself, we have different tests to look at the function of the balance canals, which are these two tests here, or these tests here. We can also look at the function of the utricle and the saccule that I mentioned. That's these tests here. We can measure how these ocular motor functions work. Those are the ones that control eye position, so we can keep our vision focused. Those are the tests that are related here. And then we can also measure how we maintain posture, how we maintain neck position on our shoulders. And that's using some of the testing that's outlined here. So different ways we can analyze the different the components of our balance system and how these things work together. So there are many different things that can cause dizziness and balance during the aging process. As I mentioned, by far the most common is benign paroxysmal positional vertigo, even though it can be very frightening because the nystagmus and the vertigo can be they can be very dramatic, even though they're very brief, very treatable, and something that I would initially recommend going through physical therapy. Meniere's disease we talked about, even though it's not as common in the younger population as migraine, it is more common than vestibular migraine as people become older. So there may be individuals that have sort of the end result of Meniere's disease may be a loss of balance function in one ear. And that may be more common in the elderly than vestibular migraine. There's orthostatic dizziness we talked about that really is related to changes in blood flow to the brain. So there can be many things other than just low blood pressure when you get your blood pressure checked when you're in your doctor's office. Central vertigo can be related to multiple kinds of neurologic conditions that could potentially cause dizziness or vertigo. Bilateral vestibular hypofunction, I mentioned, can be associated with the aging process. The main thing that usually makes us suspicious of this is that people that have more problems in the dark. So they seem to do fine when they're out during the daytime, but if they're trying to walk in the dark, especially if they're walking on an unstable surface, like on gravel or something like that, or slippery ice or something, those we would always be suspicious that there may be a decline in bilateral vestibular function. That's related to peripheral neuropathy, where again, if you have both of these things, it's even going to be more disabling. And all these things can lead to a fear of falling, which in itself is a risk factor for falls. So it's really critical to intervene early. So sometimes it might actually be your inner ear. And I'm happy to take any questions.
Wow, that was the most educational presentation I've seen on dizziness. I learned a lot.
So a couple of things I can mention. One is that if you're looking for some kind of a good resource to learn about balance disorders, the one site I would find that I would write down just to get some reliable information is this one here, vestibular.org. It's the Vestibular Disorders Association. And they're an amazing patient and professional support organization with really reliable patient education information and resources to find physical therapists and other individuals to help you with dizziness and balance problems. So probably the most reliable place to look for this kind of information. Mm-hmm. If you're really kind of a technical person and you want to just, what I would think would be fun, you may find it maybe not so much fun. There's actually an app for your phone, if you have an Apple type phone. It was written by an individual who does a lot of research in balance disorders. And it can actually show you how some of these balance pathways work and how they control eye movements. So if you're interested in sort of the more technical aspect of it, you might find that entertaining and educational. So something else you can look at.
Dr. Hume, I was diagnosed with Meniere's disease in my 20s, and I have not heard it before classified or mentioned in the category with autoimmune diseases. So, and I guess my question is, it seems like I'm developing a few more autoimmune responses as I get older. Alopecia universalis being one of them. So is there any correlation between having one autoimmune condition and multiple autoimmune conditions?
So there is Meniere's disease. So even though it's one of the theories for Meniere's disease, I'd have to say there's not a lot of, actual support for that theory. And really my point in that, putting that up there, was that we really still don't understand what causes that to start. But certainly if we ignore Meniere's disease, there is certainly some evidence that different kinds of autoimmune disorders may be connected. And obviously that has to do with how the immune system is regulated. And the triggers for that can be more common viral disorders, which may trigger autoimmune disorders. And the understanding of the genetics of that is interesting because it may relate not only to whatever viral infection might have triggered it, but also your very specific immune system and how it reacts to infectious agents. So it's probably an interaction between genetics of the immune system and environmental exposures. And in some sense, that may be the same for Meniere's disease, if we don't understand it as well.
Thank you.
Are there any other questions?
Larry? Yeah, can we get rid of the screen, the PowerPoint, so we can see one another?
Let me see if I can stop my sharing here.
Sure.
Did that give you back the screen?
Yes. Yeah.
Okay, sorry about that.
Yeah, that's wonderful. Yeah, and I have a question.
Sure.
I may have missed it, but I have just a simple question, I think, which is how much would you, do you see hearing loss and dizziness or peripheral vertigo in people? Because I think that's where so many of us suspect we have imbalance or whatever because of our hearing loss.
So it's, I agree, it's a straightforward question, but the answer is not straightforward. So two things, just like we associate, as I mentioned, there's an association between loss of balance function in the inner ear and how the brain interprets that with aging. Just like there's, in general, an association of hearing loss with aging. Some of those factors that affect hearing loss with aging and balance loss with aging are obviously related to the inner ear, because the structures, the hair cells and the nerves that innervate those structures are very, very similar. And they're affected by similar processes associated with aging. So just like people lose hearing with aging in most cases, that can be lost, that can be hearing loss related to loss of hair cells and loss of the neurons as well. So those are very similar. So in the sense that they're often seen together, and obviously because it's all related, those are both related to the inner ear, they're connected through that. But that being said, not everybody that loses hearing with aging loses balance function. So we can see individuals that have completely normal hearing who have lost all balance function. So when we do our tests of balance function, even in the laboratory, they've lost everything, even though they have normal hearing. And in a similar fashion, we see patients who we are, for example, evaluating for surgery. So any patient, for example, that I see that's being evaluated to have a cochlear implant, who may have lost all their useful hearing, we actually test balance function in all those patients. And we find that even though they may have lost all hearing, many of them have excellent balance function. So even though they're commonly associated with the aging process, there are exceptions both ways. So people can lose all balance function and maintain hearing, or they can lose all hearing and maintain balance function. And we don't really understand why that happens. So you're correct, they often go together, but not always. And also related to your question is that, for example, with balance, there's actually a little bit of information that hearing actually contributes to balance. So if we look at people, if you actually eliminate hearing signals, that can worsen somebody's balance. So that's something that's a little bit surprising. But if you think about it, hearing is not just the sound, it's also localization of sound. I mean, it's fascinating, right? Because that means that some of our awareness of your position in space is related to the balance system, which is detecting head movement and body movement, but it's also related to the sound input. So your ability to localize sound and localize your body in space is also related to hearing and vestibular function. And as I kind of showed in that summary slide, what's also really fascinating, I think, is that as we learn more in the last, maybe 5 to 10 years, the links between vestibular loss and hearing loss and cognition, and those links, we initially were thinking those might be just an association, but it appears there might actually be a causative role. And that's interesting because it means there might be a role for intervention in treating hearing loss or treating balance problems and maintaining cognitive function. So there's a lot of information that shows that the balance system, as an example, there are direct neural connections between the balance system and the centers in the brain that are important for learning and memory, which that area is called the hippocampus. So we know that if we eliminate balance function in a surgical procedure in a model system, that actually affects ability to perform memory tasks. So there's a very complex interaction between the hearing and balance systems and cognition and how those are affected by aging, but they don't always go together. And so I think it's, there's still a lot to learn.
That's great. I see.
I personally had an experience. Just to close this part of the conversation, my hearing was destroyed when I was 20. At that time, I had to quit ice skating, figure skating, because of loss of balance. When I got hearing aids, I regained a lot of my balance, but not fully.
Mm-hmm.
And that was a very obvious observation experience on my part.
Yeah, I think that makes sense because they do work together, and we use sound in different ways to help orient ourselves in space too. So yeah, fascinating.
I see questions from Lou, Vicky, and Bev. Go ahead, Lou.
Okay, I have a question. Since you mentioned cochlear implants, after surgery, people have problems with dizziness, and I was wondering if that has to do with the bending of the hair cells when you put the electrode in the cochlea, or because of a loss of fluid. Second question is regarding after getting cochlear implants for 10 years now, I can fly an airplane. I never have my ears pop anymore.
So for the first part of the question, having a cochlear implant, as I mentioned, there is some information on this. But having surgery to put in a cochlear implant does not necessarily cause any loss of vestibular function. So we test all of the patients that I do for cochlear implants, we test their vestibular function before. And if they have any symptoms afterwards, we do test them. So we know that most people who have a cochlear implant do not lose balance function in their ear, but some do. And the reason that happens, we don't know for sure, but obviously when we put in a cochlear implant, you're making a hole into the cochlea and then inserting the electrode, which is going to cause some inflammation in the labyrinth, which is the same common fluid space that involves the vestibular, the balance part of the ear. So in some individuals, for whatever reason, that may cause problems with balance. Now, again, it doesn't always happen, and we don't know why it happens in some individuals. But part of the complicating factor is that in many cases, we don't know, in other situations, we don't know how much balance function was there before you had the surgery. And unless we know that, we don't actually know if there was an impact of the surgery, because we actually have the other part of the equation that we're not really measuring in the situation is how the brain can compensate. And by that, I mean, if there's damage, even if there's a lot of damage, with time, the brain can compensate and recover by sort of adjusting how it maintains those inputs. So using your plane analogy, is that if you have a plane with engines on each wing, if you lost the engine on one wing sort of suddenly, that would be a disaster. But if you gradually compensated by the controls of your airplane, you might be able to fly with just one engine on one wing. So that kind of a compensation is what your brain does if you lose function in one ear. It becomes more complicated if you got a cochlear implant in both ears, because then you might have lost some balance function in both ears, and your brain has a lot more work to do to compensate. So it's hard to know without, in your specific case, but again, it's not a given that everybody will lose balance function with having a cochlear implant. In fact, it's fairly unusual. Now, related to pressure changes after having had a cochlear implant, most likely thing with that is that the pressure change that we experience with flying and changing elevation is related to how well the eustachian tube works. And that's the valve sort of at the back of your nose that equalizes the pressure in the middle ear. When you have a cochlear implant, all those cells in the mastoid bone are drilled out. So it enlarges that airspace. That's basically, in order to put the implant in, we have to do that. So by enlarging that airspace, as well as changing kind of the configuration of the mastoid bone, it probably affects how the pressure is equalized in the middle ear. And so it may be that in your case, that's what was affected by having the mastoid surgery, essentially. So not directly related to the cochlear implant, but maybe related to having had the mastoid surgery.
Okay.
Vicky?
Is the Brandt's maneuver still used? I had a severe episode, the only one I've ever had, of vertigo about 30 years ago, had no access to a second person to do some other maneuver that took two people to do. And the Brandt's maneuver was very helpful. It's what undid the vertigo. So is it still used?
Yes, I just showed the Epley Maneuver kind of for simplicity, but there's a number of different movements that have different people's names attached to them. But it turns out, especially if you have involvement of that posterior semicircular canal, there's a number of things that are very effective. So yes, we still use the Brandt maneuver.
Thank you.
Beverly?
Dr. Hume, can you run this by again for me? All you have said? I'm joking, of course. But did you say at the beginning you have a lecture like this on video, or I could go to YouTube or anything like that to catch your program again?
I don't have this. I have a link to one that's a little more technical through the geriatrics department that I actually did recently. And I think somebody's recording this one, right? I don't know if you put them on a website or anything.
Yes, it's recorded and it will be available
Yeah, good.
on our website and on our YouTube channel.
Okay, I have one other statement to make here. I found a valuable resource on the internet. I rely on them, but I'm very picky about what I choose. I hope you can see this. Is this on the screen easily enough to read?
Yes.
Put it a little closer.
Say when. I can't really judge from.
This
Oh, okay.
Vertigo, Part 1, Research on Aging, University of California, 2018. Is that a YouTube?
Yes, this is a place you go on the YouTube. If you just type in what you see on the screen, there's part 1 and there's part 2. Both of them are about an hour. They are extremely well done by these physicians, this lecture, and especially geared towards seniors. It's a little less technical than Dr. Hume, so it may be a little easier to absorb what they're trying to tell us, but I found it most helpful. Don't try to do it all in one day. Watch it a little bit at a time. And but for professionals who know what they're talking about, like Dr. Hume, it's invaluable. And in fact, I would say the people that have been most helpful for me, because I was diagnosed with Meniere's and also had a big problem with vertigo and tinnitus, the whole package. And so the best places were here at this HLA organization, particularly Neil Bauman, who helped me a great deal with tinnitus, and he's just a walking dictionary on everything related to tinnitus. So I'm grateful for him. Also, I cannot thank enough my physical therapists that I've had, and dealing with dizziness and exercises and what I could do. And I followed her directions all the way. I'm still practicing them. It's still 3 years since I've seen her, but they work. And then last but not least, a chiropractor. He was the one that taught me the Epley Maneuver, and he also determined that mostly my violent bouts with vertigo were positional ones, and he could deal with that and teach me how to determine whether it's the right or the left side of the head that's affected. And so all these people, I am ever grateful to for what I have gotten from them. And thank you for your contribution, Dr. Hume.
You're welcome.
Any other questions? Charlene? Go ahead, Charlene. You're on mute.
Dr. Hume, I'm wondering if the medical profession is doing any better overall in dealing with vertigo. So many of us in years past have said that all we got was something that was like a sedative to calm us down that didn't address the vertigo at all. And it wasn't until we found physical therapists like the one Bev mentions that we got some relief.
Well, I think the reason, so as I mentioned, I think there's, from my perspective, there's still an underappreciation of the negative side effects of medications for the most common types of dizziness. So again, by far the most common one is that VPPV, which sounds like there are a number of you who have experienced. The treatment for that is not medications, but I frequently still see people who have been to the emergency room that clearly had VPPV, and they were given different types of anti-vertigo medications, which is completely, not what we would recommend. So I do think there's a big need for better education in emergency rooms and primary care providers that for many of the types of dizziness conditions that we see, in fact, the most common ones, the treatment really isn't medications, the treatment is physical therapy. So we, as I mentioned, I rely on a very large number of physical therapists scattered around the Northwest. And I would agree, they do the lion's share of getting people better. And the reason is, as I mentioned, that for most of the disorders that we see, if there's a loss of balance function, there's not a specific treatment that's going to make that better that's medical. So there are certain situations, it's that 5 or 10% that need a surgery. But most people, what they need to do is actually to have their brain make the compensation changes so that it can accommodate what's happened to their inner ear. And that's done through physical therapy. And even among physical therapists, as some of you may have experienced, there's also a challenge with education. And so many physical therapists are used to dealing with people, say, with orthopedic problems, and they're not used to people with dizziness problems. So they may see somebody who has, for example, bilateral vestibular hypofunction and chronic dizziness, and they may do an Epley maneuver, which has absolutely no reason that would help them do better. So I think there has to be more education of medical professionals, whether it's, MDs or physical therapists, so that people get the appropriate treatment. That certainly is an issue, I would agree.
Yeah,
We're very
thank you.
We're very fortunate in Bellingham. We have a couple of very experienced physical therapists who deal with dizziness, and Marga Malone, some of you may know, is one of them. And if you ever need information
Yes.
about that, you could contact me. So we now have a couple of physical therapists that are experienced. So,
Yeah, you definitely have some good resources up there. I agree.
mm,
Can you hear me?
yes,
Can you hear me?
yes.
Oh, okay, good. I just want to thank
Yes.
Dr. Hume so much, because I learned so much this morning, and I realized I got to do more reading because there's a lot of technical aspects to this. So thanks a lot for your comprehensive talk this morning. It was fabulous. Thank you.
Thank you. Thanks for inviting me.
Any other questions? Well, thank you very, very much, Dr. Hume, for joining us today. It was most informative, even for myself. So I'm going to have all my staff watch this.
Thanks very much. Have a great day.
Thank you, Dr. Hume. We really appreciate it.
My pleasure.
And thanks everyone for joining us. Next month, Pam is going to cover, there's an app for that. So I think we'll get lots more practical advice there. Just like Dr. Hume gave us some practical suggestions. Pam is going to help us with some apps that will ease our stress level, I believe. We look forward to that. And I don't have anything else. Does anyone have anything that they'd like to finish up with? Any thoughts?
Larry,
Yes. Go ahead, Char.
I just wanted to say that Doris Canop this Tuesday of this week celebrated her 95th birthday.
Oh, wow.
Oh, that's fantastic. Yes, Lou. You're muted.
On that same note, I'd just like to mention that yesterday, Ted Atkins hit his 83rd birthday.
Oh, good, Ted.
Who?
Happy birthday.
Who are we talking about? Who are we talking about?
Ted Atkins.
Thank you very much.
Oh, okay.
As my present to you, Ted, I'm not going to sing you happy birthday.
Thank you.
You're welcome, Lou. All right, everybody. It was great. I don't know about you, but I sure hope we can get back together in person soon. I just kind of an informal poll here. Is everybody vaccinated, or
Yes.
we're going to have to think about how we want to see if we can start reconvening. So I don't know. Any thoughts you have on that? Let me know. It sounds to me like the advice that came out of the CDC this week was more encouraging of us being able to get together even inside. So we'll have to see how that squares with whatever Governor Inslee comes up with as we move through the protocols here. But I'm missing Joanna's sweets and all that stuff. So yeah, Lou.
I would say that if we go back indoors, the one thing I would miss is the captioning. However, we often have CART, so that relieves that issue.
Well, you know, we've got Gretchen, who couldn't join us today because it was her anniversary and she and her husband are out of town. But Gretchen, we will, you know, we'll be able to have captioning when we're back in person. The part I'll miss is the recordings, to tell you the truth. Once we can get these up posted, it's a lot easier than what we do when we've had a videographer in the meeting and we have to try to edit those and do all that kind of stuff, right, Bev? We've been through that, haven't we? So there's been some advantages to Zoom, but personally, I feel a little disconnected from people. And you know, that's the thing about our group that has always been the most important to me, are the personal connections. So that's what I would like to get back to. All right. I'll be in touch. And as always, if you have anything news-wise or that you'd like to pass along, get in touch with me and we'll do that.
Wait.
Yeah.
Charlene and Ted, I think, had something to say. Go ahead, Ted.
Okay, Governor Inslee announced that by June 30th, we would be released on this COVID thing for us to have shots.
Well, that's great. I hope we can, I hope that happens. Because then, you know, maybe we can actually have our summer potluck. I agree. Charlene, did you have something?
You're on mute, Charlene. You're on mute.
I would hope that we don't have to do either or, because captioning helps us reach people who have to come at a distance or not come at all, including reaching out to the state who doesn't have any chapters. So maybe we could explore the possibility of both getting together and a caption meeting, or at least a caption program.
We could possibly set up Zoom at the same time, so people who can't travel can actually watch the program live. I don't know.
I don't know. I don't know how physically we can do that, but we can work on that. Joan?
You may have a lot of people that would just stay home and watch the captions instead of coming to the live meeting, though.
Go ahead, Joan. Joan, you're muted.
You're on mute. Joan, you're on mute.
Joan?
Go to the very left corner of your screen, and down below there's a microphone. Just click on the microphone.
I'm enjoying lip reading her.
All
There you
right.
There you go.
Okay, I got it. The little microphone wasn't there before, but no, if we could have our meetings so that like our borders still closed, and it would be really nice to be able to attend your meetings. And I don't know, I'm not very techy about all this, but it could be looked into, and have it on Zoom as well, or if that's possible. Okay, thank you.
Yeah, Vicky?
I think if I read the CDC's recommendation correctly, I think the CDC is now saying that fully vaccinated people are likely okay to gather indoors and don't have to social distance, don't have to wear masks. But I think that directive raises a whole host of other problems. And as eager as I am to get back together again, it seems like the CDC's directive could be very divisive, because you have the haves and the have-nots, as it were, and what do you do? So Larry, I'm glad I'm not in charge, because I think the decisions are going to be tough.
Well, I'm glad we make group decisions, because
Yes,
I don't want to make
yes.
a unilateral decision either.
Yeah,
Of course, everyone will have the opportunity to decide whether to come or not to come.
And every small group, every group is going to be faced with the same kinds of decisions. And I think it's going to be really hard.
I agree.
I definitely agree with what she has said. And there are a lot of us that are not so keen on vaccinations, not at this point. And so, yes, it would be an issue for me too. And so I think we have to consider that. It's something that's going to take over the whole nation in terms of an issue.
Well,
At
okay.
the moment, sorry.
Go ahead.
We do have to follow state guidelines from Governor Inslee. And he is saying that we remain in phase 3, starting, everybody will be in phase 3 starting next Monday. And then he will evaluate again to see how we're doing. Whatcom County is not doing very well. And we've had a nursing home where 16 or 19 people got COVID just recently. And some of these people were vaccinated. So it's a bit of a shock. And I think at the moment, in my clinic, I'm still taking every precaution. And I think as a group, we need to pay attention to what's happening. And
I agree. I don't think we have a decision to make right now. My understanding is the CDC may have said one thing, but so far Inslee has not said the same thing that the CDC is saying. So we're gonna be as safe as we can be, but we'll wait, and when there's some information that leads us to believe we might want to revisit the decision, then we'll revisit it. For right now, we're Pam's going to do her, there's an app for that on Zoom next month. And then we'll see where we are. We've got, I believe August is the potluck. So that's not a Zoom program. That's not something that we have to decide. So we're probably looking at September. I think the big decision point that I see coming up is what to do about the Gail Hannon event. Which is scheduled for October. And we had, as all of you will recall, we had anticipated using that as a community-wide event. And I'm still not convinced that that would be a wise thing to do. I think there are a number of people in the community who would be hesitant, but we'll have to see how it plays out as we get a little bit closer. The issue there is going to be timing on getting a venue if we decided to do a community event. But we don't have to make those decisions today. I think we should all decide to go outside and enjoy the sunshine and get some vitamin D going and have a good time. Try not to work too hard in our gardens and outside and doing all of the yard work that we've all been putting off for, at least we have at our house for a while. So unless anybody has something else, let's sign off for now. Hold on, Becky. Hi, Becky. Go ahead. You're muted.
Hi, I just wanted to thank Erlene for inviting me to this meeting. I enjoyed it, and I look forward to future meetings.
We look forward to seeing you again.
Thank you.
Thank you for joining us.
Thank you.
Okay, everyone. Thanks.
Thank you.
We'll talk soon.